All right, welcome everyone. Today we're going to break down a really fascinating clinical sign, pathologic startle.
We all startle, right? A loud noise, someone sneaking up on you. It's a totally normal human reflex. But what happens when that reflex goes into complete overdrive? For some patients, this response is so severe, it actually becomes disabling. So let's explore why. So, here's our roadmap for today. First, we'll pin down what this thing actually is. Then, we'll jump into a case to see it in real life. After that, we'll put on our thinking caps, think like a clinician, unpack the causes, and then wrap it all up with a high-yield review.
All right, first things first, let's really define what we mean when we use the word pathologic here.
Okay, so this is so important to get right. We're not talking about a little flinch. This is a violent, exaggerated reaction. And get this, it's often triggered by something super minor, like just a simple touch. It's a whole body thing, right? A sudden flexion of the trunk, the arms, the legs, so powerful it can literally knock a person off their feet.
Definitions are one thing, but medicine happens with patients. So let's make this real. Let's meet a patient and see how this might actually show up in your clinic.
So in walks Mr. Jones. He's a 55-year-old guy, and he's here because of what he calls violent jumping spells. And you can tell he's not just a little worried. This is really disrupting his life. And listen to this detail because it's everything. He tells you that a simple, unexpected tap on the shoulder is enough to make him jump so violently that he falls over. That right there, that's your huge red flag. A fall tells you this is way beyond a normal reflex. Something is seriously wrong here, and we need to figure out what. Okay, so you're the clinician. Before you even think about ordering a scan or an EEG, your most powerful tool is your history. There is one question, just one, that's going to crack this case wide open and split your differential diagnosis into two completely different buckets. What do you think it is? Let's dig into that. Let's see how asking this one thing brilliantly organizes our thinking and points us in the right direction. And here it is. This is the absolute crux of the workup. You have to figure out if your patient is in a persistent state of autonomic hyperactivity. In other words, are they anxious, shaky, on edge all the time in between these startling episodes, or are they totally calm? This is the fork in the road, because one path leads you to a nervous system that's just on high alert 24/7, and the other path points to a very specific, broken reflex circuit. So check this out. Look how beautifully this organizes everything. On one side, if the answer is yes, there's hyperactivity, you're thinking things like PTSD, generalized anxiety, maybe alcohol or sedative withdrawal, things that rev up the whole system. But if the answer is no, they're calm between episodes, your brain has to completely pivot. Now you're in the world of neurology. Things like brainstem lesions, rare genetic conditions like hyperacplexia, or even something as scary as Creutzfeldt-Jakob disease. So let's go back to our patient, Mr. Jones. You talk to him more, and it turns out he's perfectly calm between these spells. No anxiety, no tremors, and just like that, boom. With that one piece of info, we've basically crossed off that entire first column. We can now focus our investigation squarely on the neurological causes. Okay, so we've really narrowed the playing field. Now let's dive deeper into these neurological possibilities. These are less common for sure, but they are absolutely critical to know. So how does this actually happen? Well, this diagram lays it out perfectly. The startle reflex is super primitive. It's hardwired into our brainstems, specifically around the pons. Now, normally, your higher brain centers, the cortex, are constantly putting the brakes on this reflex, right? Keeping it under control with inhibitory signals. But what happens if you get a lesion there? Maybe a tiny stroke, or an MS plaque, or an artery is just pressing on the brainstem. Well, that can damage those inhibitory pathways. The brakes are cut. And now, a totally normal sensory input leads to a ridiculously exaggerated motor output. That's your pathologic startle. Okay, this is a super high-yield point, a classic exam question. You have to be able to tell the difference between pathologic startle and startle epilepsy. They are not the same thing. In pathologic startle, it's just a crazy, over-the-top reflex. In startle epilepsy, the surprise stimulus actually triggers a full-blown seizure, usually a tonic seizure where the body goes stiff. The typical patient is often different too. Startle epilepsy is often seen in kids who have other significant neurological problems. And medicine is full of fascinating stuff. Just to round things out, you should be aware of these other rare causes. There's hyperplexia, sometimes called stiff baby syndrome, which is a genetic cause you see in infants. And then you have these really interesting culture-bound syndromes, like the jumping Frenchman of Maine, where the startle comes with other weird behaviors like cursing or automatically repeating what people say. So just keep those in the back of your mind. So how do we treat this? Well, it follows our logic perfectly. Step one, always, is to treat the underlying cause. If it's an artery compressing the brainstem, maybe a neurosurgeon can help. If it's anxiety, you treat the anxiety. But if you can't fix the root problem, or if that doesn't work, clonazepam is often the go-to. It's a benzodiazepine, and it basically works by boosting GABA, which is our brain's main inhibitory neurotransmitter. It's like we're trying to chemically put those brakes back on the reflex.
Phew. Okay, that was a lot. So let's do a quick-fire review to really lock in this knowledge, especially for your exams.
All right, let's put this into practice. Case 1. A combat vet with constant anxiety, nightmares, and a severe startle. Which category are you thinking? That's got to be with autonomic hyperactivity, right? Most likely PTSD. Okay, case 2. An infant who, since birth, has these violent, stiffening jumps whenever there's a loud noise. What about that? That's the without category. You've got to be thinking about hyperplexia.
All right, self-test time. Question 1. What is the single most important clinical question to ask when you're evaluating pathologic startle? It's all about whether there's persistent autonomic hyperactivity between the episodes. That's your big branching point.
Question 2. Name 2 structural causes of pathologic startle that you'd find in the brainstem. Yep, things like a pontine infarct, an MS plaque, or compression by a funky-looking ectatic artery are all great answers.
Okay, last question. How do you tell the difference between pathologic startle and startle epilepsy based on what's actually happening during the event? Right. Pathologic startle is an exaggerated reflex. Startle epilepsy is a true tonic seizure triggered by the startle.
Okay, let's boil it all down. If you're going to remember just 4 things from today, make it these. Number 1, pathologic startle is a violent, exaggerated reflex to a minor stimulus. Number 2, the key diagnostic question is always, is there autonomic hyperactivity between spells? Number 3, with hyperactivity means you're thinking PTSD, anxiety, or withdrawal. And number 4, without hyperactivity, your brain should jump to hyperplexia and brainstem lesions. Got it? That framework will get you 90% of the way there.
You know, when you really think about it, pathologic startle is so much more than just some obscure clinical sign. It's a really powerful reminder of the profound, delicate balance our brain maintains every single second. It gives us a window into these complex inhibitory circuits that are constantly working, totally unseen, to keep our most basic reflexes in check. It's a stunning example of what happens when those brakes fail.